Okay, guys, so let's continue with our questions, and I give you 30 minutes so you can pause the video and 1 minute to write the answer. So you have obtained an X-ray of facial bones. What is abnormality seen on the X-ray? What does it signify? What you see is air in the right orbit, suggest giving eyebrow sign, suggestive of orbital fracture. You have asked maxillofacial unit to review the patient. They've looked at the CT as per prescribed and happy to discharge. What advice and treatment? So the advice and treatment which you will give is you will ask the patient, you'll put the patient on antibiotics, comoxiclav and azithromycin, paracetamol for pain. Do not blow the nose. Ophthalmology in 7 days. Head injury advice. And the indications for surgical management is an ophthalmos greater than 2 millimeters and diplopia, that is entrapment, and fracture greater than 50% of the orbital floor. Next one, pediatrics. So again, pause the videos, take 1 minute to write down the answer. So what bedside test is indicated and why? So this is a small little boy, so we have done a urine test, so you can't say urine, you will say a capillary blood gas to look for lactate levels and base deficit, and that should be it, just to look for lactate level and base deficit to rule out septicemia. What to initial treatment will you commence? Give dose, IV fluid, 0.9% normal saline, 20 ml per kg stat, and that is for the heart rate and the blood pressure. And ceftriaxone IV 80 milligrams per kg. The patient needed 2 doses of your initial treatment, so we have given 2 boluses of IV. That means what intervention? People who have received 2 boluses needs tubes everywhere. So you need to do, anyone receiving more than 40 ml per kg of fluid resuscitation will get rapid sequence intubation and ventilation because there is risk of pulmonary edema. Peripheral inotropes, ideally dopamine IV or adrenaline IO, central venous access, urinary catheter, nasogastric tube. Next question, again pause the video and write down your answers. Okay, so give 2 historical features. So risk features we have to give for a CT scan. See to it that we don't repeat what is given in the question stamp. So GCS will not be there. 3 episodes of vomiting will not be there, and mechanism of injury is very low mechanism of injury, and there are no fits or no basal skull fracture signs. So what will you see is you will say amnesia more than 5 minutes, loss of consciousness more than 5 minutes, child just has one risk feature. So what we'll do is he just has one risk feature. If you notice abnormal drowsiness and more than 3 discrete episodes of vomiting is single feature. If there are more than 2 features, then you do a CT scan within an hour. But if there is just only one high risk feature, we will just observe the child for 4 hours. And if there is a further decline in level of consciousness, that is GCS goes down below 15 and further episodes of drowsiness, or if there is further vomiting, you will request a CT within 1 hour. Next, this is a very hot topic right now going on, has been coming on for the last 3 or 4 sittings in both the intermediate and the finals, ULTI and BRUI. It's not the same, it's not a new name for ULTI, but it is a further modification or refining of ULTI. Although ULTI is mentioned in the curriculum, BRUI is not. They have been asking this question, so I want you to be on top of it. So what are the differentiating features between ULTI and BRUI? What are low risk factors for BRUI? And if the mother is anxious, how long will you observe the patient, and what investigations will you do, and what observations you would like to put on the chart. So ULTI has no age limit, but BRUI has been very clear. It is less than 1 year of age and lasts less than 1 minute. and it is characterized by color changes, change in tone and breathing. ULTI is caregiver's perception, versus BRUI, which is clinician's diagnosis. BRUI stands for brief, resolved, unexplained event, so there is no cause, whereas ULTI can have a cause. Low risk factors for BRUI: age greater than 60 days, so more than 2 months of age, born after 32 weeks, so not severely premature, duration lasting less than 1 minute, and first BRUI, and no concerning features, and no CPR given by the family members. If you are observing, you're going to observe the patient's heart rate and saturation, and if you have to do any investigation, you do only one ECG and a pertussis swab. Next one, 7-year-old African male. So pause the video. So what is the initial treatment? So this is clear-cut sickle cell anemia. So, and temperature is high, that means infective crisis is going on. What is the initial treatment? You would like to, what precipitates these crises in sickle cell? Hypovolemia, hypoxia, dehydration. So give some fluids, give some pain medicines. So fluids will be IV 0.9% normal saline, 20 ml per kilo stat, and then oxygen you can give. Oxygen is already on, so you can't give that. You can say IV morphine 2.5 milligrams stat, IV paracetamol for the fever. You have intubated the child, and what abnormality you see on the X-ray? Abnormality is bilateral haziness seen on the chest X-ray, more towards the right side, suggestive of acute respiratory distress syndrome. What two organisms may be implicated? Abnormalities, again, you go by A, B, C, D, E, and we'll be able to write down. What organisms may be implicated? All capsulated organisms. So they are Salmonella, Staphylococcus aureus. You have to write Staphylococcus aureus, not just Staph or Staphylococcus. Staphylococcus aureus, Streptococcus pneumoniae, Haemophilus influenza, Neisseria meningitidis, and Klebsiella. So let's move on to the next one. Pause the video again. Okay, give 2 viral and 2 bacterial causes, very straightforward. Epstein-Barr virus, herpes virus, and adenovirus. Bacterial is group A beta hemolytic streptococcus, corynebacterium diphtheria, mycoplasma pneumonia. Not staphylococcus and not strep pneumonia. It's group A beta hemolytic. That's strep pyogenes. Cantor criteria was clear, give components, and antibiotic of choice. Cantor criteria is easy to write, but what is the antibiotic of choice? Everybody is written amoxicillin or ampicillin. Remember, in the UK we don't give amoxicillin or ampicillin. We give, even if we are sure that this is a bacterial cause of tonsillitis or pharyngitis, we give phenoxymethyl penicillin. Okay, so that will be the antibiotic of choice. Apart from rheumatic fever, give 2 non-systemic non-ENT. It gives 2 systemic non-ENT complications. You can say glomerulonephritis. That's one of it, and the other one is scarlet fever. Next one, a 10-week child with vomiting. Pause the video and write down the answers. Okay, so what could be the differential diagnosis? From the picture I see a uterus type picture, but this is pylorus. So an ultrasound image showing the pylorus. So this is differential is congenital hypertrophic pyloric stenosis. In second, you can write duodenal atresia. Based on the symptoms, it's very clear. Like, child becomes hungry immediately after vomiting, and child cries when he cries, and when he cries, you'll see a olive-shaped mass in the tummy and visible gastric peristalsis. You ask for observations, what bedside test is indicated, and what is the initial treatment now. You want to do a urine dipstick or a capillary blood gas to see for the electrolyte levels, because if he's vomiting, then he may be having hypochloremic acidosis, and a urine dipstick to see for ketonemia, because they go into dehydration. Your consultant is doing an USG. What specialty it gets referred? You know the diagnosis is congenital hypertrophic pyloric stenosis. You refer it to surgical specialty or pediatric surgery, and definitive treatment is pyloromyotomy. What is the initial treatment? You can get an IV access, hydrate the child, but initial treatment will be nil by mouth. The next one, pause the video again and start writing the answers. Okay, so you've done the x-ray, so I think there is a supracondylar fracture over here. So considering that, name two structures: radial nerve, median nerve, brachial artery. These three are the things: radial, median and brachial artery. Name two structures. So that's it. What lines are drawn? You draw anterior humeral line or radiocapitellar line, and the angle is humeral capital angle, humeral capitulum angle. Okay, that is calculated as well. The indications for operative repair is neurovascular deficit, greater than 50% displacement, 20% posterior angulation, or 10% medial or lateral angulation. This is clearly given in the guideline. Okay, this was another difficult one. Pause the video and start writing. Okay, give two duct dependent left heart lesions. So left heart lesion will be hypoplastic left heart syndrome or coarctation of aorta. What assessment approach is essential in this child? ABCDE approach. Any sick patient, ill patient, ABCDE approach. Where would you feel the pulses? You will feel the femoral pulses. Okay, not the brachial pulses. Brachial pulses are felt in a patient who is arrested or peri-arrest. Okay, and where would you measure oxygen saturation? You need to measure oxygen saturation on both sides of circulation. So one should be on the right hand and one should be on the left hand or the left leg. No earlobe. If there is no murmur, this is primary pulmonary hypertension. So what medication should be given and what should not be given? So duct dependent lesion is coarctation of aorta, aortic stenosis, left hypoplastic heart syndrome, ABCDE approach. Femoral pulses should be felt. If there is no murmur and femoral pulses are present, it is pulmonary persistent hypertension. They will benefit with nitrous oxide. Don't give oxygen. So this is it. If you go on the link which I have given, there's a very nice framework which they have put up. This can be asked, but the approach to care is a part of the curriculum. Details are not necessary. So just there is a nice flowchart of assessment and causes. If you can memorize the flowchart and the causes, that should be enough. Next. Okay, give two differentials for a pediatric limb. First is superior upper femoral epiphysis. So slipped upper femoral epiphysis. Second is Perthes disease can be acceptable, or transient synovitis can be acceptable. You have requested his X-ray. An image is given. So how will we start doing it? You will say that there is a slip of upper femoral epiphysis on the left side, which is clearly evident. There is marginal slip of right femoral epiphysis as well. If you look at the picture properly, it looks like an ice cream cone if you look at the femur, and the ice cream is melting on the right side. That's another way to remember it. Usually these are bilateral. If the patient is obese and there is underdeveloped genitalia, and the patient is normally built, the genitalia is normal. Usually they are bilateral, so the orthopedic surgeons might want to fix the other one prophylactically as well. The radiological line drawn is the line of Klein, not the Shenton's line. Shenton's line is used for the fractured neck of femur. Radiological line is line of Klein, and the sign which is present is Trethovan sign.